The treatment of rib fractures had not changed for thousands of years until really the advent of mechanical ventilation and positive pressure ventilation, which was probably about 50 years ago. A majority of rib fractures do not need to be fixed. However, over the past 20 years or so, there have been significantly increasing interest in operative rib fixation. Our techniques to fixing ribs, generally we try to do as minimally invasive as possible, and this has really almost revolutionized the way we do the procedure. Now, in the elderly patients, there's no question that rib fractures tend to affect them even more than their younger counterparts. And, obviously there's multiple reasons for this. The most common being that, older patients generally don't have as much physiologic reserve, so they succumb to all the sequelae from rib fractures, i.e. pneumonia, atelectasis, pulmonary insufficiency, and sometimes even requiring mechanical ventilation and tracheostomy. And in studies that have been done in the past, up to 60% of patients with a clinical flail chest are not able to return to their same level of functioning even at the 5-year level. It's for these reasons that we took a specific interest in rib fixation. And, for the longest while in medicine, there had been sort of a tendency to not be as aggressive in older patients because they may not be able to tolerate these operations as well as their younger counterparts. However, what we found is that we actually need to be more aggressive in these patients because of their lack of physiologic reserve. And the earlier that we can get the ribs fixed and get them breathing and out of bed, the better they do. And I think it ties in very nicely with our G60 program because it just, once again shows that, the sooner we get these done, the better. And many of them are actually able to go home as opposed to going to nursing centers or inpatient rehab centers. And we're clearly delineating this in the data that we've collected thus far.